Well, for the rest of them who didn't come, they're lost. We're only trying, but welcome everyone. Thank you for coming. As you see, we're trying to do more grand rounds for the entire institution. This is our fourth one in the last 8 weeks, and we'll keep going. So we need some help with ideas if you guys want other topics or if you know speakers who are willing to speak. Anyway, I'll keep this short. So Dr. Iliakova is joining us starting next week officially. She'll be one of our new bariatric and minimally invasive surgeons. And she graciously offered to give us a talk. So thank you so much. And I think this is a topic that's quite important to all of you, right? We see this all the time. And she'll give you some info. So thank you. Thank you.
Thank you so much for the warm welcome, Dr. Sarin and everyone here. Like I mentioned earlier, this is going to be pretty interactive. So if you have experience, if you have questions, jump in. You're welcome to do that. And I'm really glad you're here. So it may be a little funny to have a surgeon come and give you a talk about medications, but starting about 4 years ago when I was in fellowship, this became a really big deal as the FDA started to approve GLP-1s and other medications for weight loss. So we actually learned it as part of fellowship, and I have had it as part of my practice from day one as an attending. So really wanted to share some of my experiences and do a little bit of review. Hopefully that some of this will be new and novel to you. Some of it might be review, but yeah, excited to be here. So we'll be covering today obesity as the bigger picture and talking about some of the implications overall as to why we really should be caring about obesity. And then overall going through the entire medication toolbox. So this is a bit of a pictogram of like the spectrum of the med toolbox, the checklist of indications, some warnings, when to consider surgery, and then some special considerations like what to do about low BMI patients and what to do to taper medications. Yeah, so this is me. I have a dog, as you can see on the right. I'm a bariatric and general surgeon, and I start now, which is great. I have been the medical director of a robotic program before and a bariatric surgeon. And I do a lot of things in this field. I actually have a podcast with my former coordinator. We did about 6 months of podcasts on different topics, addressing everything from constipation to medications to how to eat after surgery, and actually created an AI-driven patient assistant called BariBuddy for patients as well. And I'm really active in SAGES, ASMBF, OMA, etc. So love this topic. It's really fascinating to me. By the way, our program coordinator, Andrea, is here in the audience today, and she is a really excellent go point for our program. She's been here for many years with a little bit of a gap in between, but is an extremely great wealth of knowledge for everything bariatrics. So she's just a great person to know. So overall, the big picture, I think a lot of us probably know this, but sometimes we don't actually put the numbers to the real data out there. So obesity costs over $1 trillion. In the US. So it literally is one of the biggest drivers of cost, no pun intended, in the entire healthcare system. And we know this because at this point, obesity is so common, it's become the baseline for most of our patients. We don't even see it anymore. We don't even see it as a medical condition anymore. There's a recent JAMA article that came out that included anthropomorphic or metrics such as waist circumference, and other things that would actually classify 70% of adults as obese. When something is 70% of the population, it's a really big deal. However, less than 10% of patients actually get any treatment for their weight. I think that's pretty stunning. And I'm not just talking about bariatric surgery, that's everything included, that's medications. And you're saying, okay, well, everyone's on GLP-1s, how could this possibly be true? We see a very small slice of the population. We see those who may have insurance, who may have access, but 90% of people are not being treated for obesity. So huge numbers there. And then I just wanted to cover really quickly some of the myths, because especially when you're in this field, you hear this a lot. Oh, it's just a problem of willpower. People should eat less, exercise more. It's all about vanity. Why do we care so much about obesity? It's not that hard. And I'm going to burst those bubbles a little. You probably have, some of you may have tried diet and exercise yourselves. All of us have patients or family members or friends that have tried. In fact, literature says 95% of people who try diet and exercise alone fail. Not only do they gain weight, they usually gain more weight. And there's a lot of good metabolic reasons for that we will cover. Insurance coverage is extremely limited to treat weight, even though it's one of the biggest healthcare problems in our country, arguably the world. A lot of what we can do for people is based on what insurance they have. Yet, all of our data, all of our research, all of our guidelines says consider treatment early. So a lot of folks, if you're out in the community, they're like, oh, surgery and meds, this is just for people who are 600 pounds, much bigger. But actually, there's a lot of data that shows we should be considering meds at any BMI over 25, and we should be considering surgery at BMIs 30 plus, not very high, if you think about it. All right, so let's talk about the spectrum of care. There's a big shift towards understanding that obesity is something that people face throughout their entire life. It's not like you're obese for 5 minutes or 5 days or 5 months. If you have obesity, it's extremely likely this is a lifelong condition for you. So we have to think of how to treat it over that span too. Nutrition, fitness, and mental health are going to be treatments and approaches that apply to absolutely everybody. Medications start to apply to those that have BMI 25 plus, and surgery, right now at least, under most insurance policies, is limited to those with BMIs 35 plus. Hopefully that will change. So ASMBS, which is one of our big metabolic bariatric surgery and treatment organizations, actually recommends surgery for BMIs 30 plus. And this is guidelines that came out in 22. So since the height of COVID, we have been recommending as the leading organization in this field that people be treated with surgical interventions at BMIs of 30. Just a quick show of hands, did anybody know that coming into this talk? Yeah, the entry you don't count, but thank you. BMI of 30 is not much. So a patient who's 5'5", which is my height at 200 pounds, is over that limit. That's a 33 BMI. That's a 200-pound patient that would qualify for surgery under this guideline. So that's a really low number. I see some of your faces being very skeptical and not believing that, but that's a true, very well supported in literature and evidence guideline that was created by an organization of over thousands of surgeons. So know that. I think that's surprising to people. These treatments really should be considered at much lower BMIs than we think of. We are here to talk about meds, though, I promise, so we'll get there. This is actually a patient that I treated in Iowa, where I was before, and she's someone who's pretty typical. She's a 40-year-old woman, principal of a high school, very busy, and over the course of her lifetime actually ended up developing hypertension, diabetes, obstructive sleep apnea, a bunch of things before her medical condition was treated seriously. So she went through a bunch of doctors actually ignoring her medical condition, and got to the point where, she was really suffering in terms of quality of life, mobility, limitations on her work even. And then after going through a gastric bypass, really had a great outcome so far and has improved her life. So overall, just want you to start thinking BMI 25 plus, start thinking medications. 35 plus, start thinking surgery, maybe plus minus medications. I'm not the only surgeon for sure that's talking about combination. You'll start to see this a lot more. It's not either or, it's both in a lot of cases, and especially over a lifetime. Specifically, when we're thinking of indications for treatment, though, I want you to start thinking of why we are doing this for patients. We're not doing it so they can lose 10 pounds. We're doing it because of what that means in their life, what that 10-pound loss or 50-pound loss or 100-pound loss, whatever it may be, allows them to do. Does it allow them to overcome infertility and have a child? Does it allow them to get up and off the ground with their grandkids and be able to live a really great life running after their grandkids? Does it allow them to fly on a plane comfortably? Does it allow them to have sex comfortably? Does it allow them to go for a 5K on the weekend comfortably? What function does it allow our patients to have that they currently don't have? Really start thinking about that, because if you put it into that perspective, it doesn't matter what your treatment is as long as we're doing it together. All right. So when do we use medications? Specifically, I wanted to touch on a few things to really highlight this for physicians. One is fertility. So over 70% of infertility is actually caused by metabolic causes, and a huge majority of that is weight driven. So even a 5 to 10 pound weight loss in either men or women can flip the switch from infertility to fertility. It's extremely under considered. So if you have someone that's facing infertility issues and you haven't considered their weight, especially if BMI is over 25, it's time to do that starting today. What about medical optimization? You may have patients with cardiovascular disease, with NASH, which is now like NAFLD and a bunch of other acronyms, but fatty liver disease, diabetes, everything else. Guess what? Weight loss and essentially all of these comorbidities improves outcomes. And it doesn't have to be drastic weight loss. It literally can be 10% of excess body weight, which in some cases is not that much. A lot of folks have surgical contraindications. If someone's trying to get pregnant within the year, if someone's had a recent pregnancies, they have end-stage liver disease. Basically, if you wouldn't do an elective surgery on them, you can't really do bariatric surgery. That's an elective surgery too. It's a great situation in which to consider medications, even if their BMI may be high. We also have patients go through drug and alcohol screens. We make sure their mental health is very stable. And a lot of folks don't have the insurance coverage to go through surgery. Those are also really great times to consider medications. And then, of course, have all of you seen patients that have had bariatric surgery, a band or a sleeve or a bypass? Anybody not seen the patient? Okay, a lot of those patients regain weight, right? And if they regain weight, oftentimes the first thing that we'll try is medications. So it's actually really common to try both. And then, of course, surgical optimization. The most common things off the top of my head is if most of your patients have comorbidities like bad knee joints, right? Some folks may need a transplant. Some folks may need a hernia repair. In order to undergo those surgeries safely, a lot of times there'll actually be BMI cutoffs in those surgery programs of 35 to 40. So even to qualify for other surgeries, that may be a good time to consider anti-obesity medications. Anyone have any others, by the way? I mentioned some, but can you think of any others? Anyone else? I try to be pretty comprehensive, but I'm trying to learn from the crowd too. Okay. And just to walk through a sample patient's timeline. So this person at 25 years old started at a BMI of 33, and you can see her progressively over the course of the next 12 years, her BMI rises despite multiple attempts to treat her. She's been treated with GLP-1s, but she stopped taking them due to cost and due to the side effects. Eventually went through a sleeve, and then eventually went through a bypass ultimately. My question to you in this is not so much the specifics of this person's case, but what could we be doing at a BMI of 33 at an age of 25 to think about what we're going to be doing long-term for her so that she doesn't end up developing comorbidities, so she doesn't end up losing her weight over this time as she goes through life changes. Can we start to think of medication sooner? Can we start to think of combining that with potentially surgery sooner? Because you can see that this patient's outcomes depends on our interventions a lot. And if we start to think about this sooner for patients before, like again, BMI of 30 is not high, BMI of 27 is not high, but that's when we really start to indicate these kinds of interventions. So think of it soon, think of it early. If you take nothing away from this talk, that's probably the one thing to take away. I also want to talk a little bit about what's behind the scenes here. What are we targeting with medications and why? Overall, we know that there's a metabolic set point in our bodies, a little bit like a thermostat. Unlike a thermostat, which you can crank down and it'll follow you. You can crank it to 72 if it's really cold. You can crank it down to 68 if it's really hot, and it will follow you. Our thermostat only goes one way with our metabolism. It only goes up over time. So typically attempts to lose weight, even surgery, even medications that will try to drag that set point down, ultimately your body will resist those changes. So our bodies are predisposed historically to periods of scarcity. We tend to hold on to weight, tend to hold on to nutrition. We're not supposed to live to be probably like 90 plus years old. So yeah, there's really no mechanism in our body naturally to lose weight once we gain weight. So what do we target? We target the mind, metabolism, the gut, and activity levels. And I was actually part of writing the obesity algorithm in 2023 for the OMA. And here's a really great slide. I think there were like 650 slides in this deck. This is one of them, of the specific targets that we have for anti-obesity therapies. There are a lot, and they range from things like leptin to ghrelin to CCK, which is what is secreted by your gallbladder. It's actually something that stimulates the squeezing of your gallbladder. GLP-1s are on here, of course, and a lot of others. There's actually some genetic targets even. There may be up to 10 genetic pathways that we can target for obesity. Only one of them has an FDA-approved medication associated with it. So lots of different pathways. Some of them have been tried and failed, and there's something like 500 plus medications in development. So the 10 FDA-approved medications we have now, that is the tip of the iceberg. And it's an extremely lucrative field. As you can see, it affects 70+% of the population. So we'll be seeing a lot more of this down the road. All right, now let's go specifically into the medications approved for weight loss. There's currently 10 of them, and we will cover the different categories here. But again, a takeaway that I want you to see In this circle, this is one of the ways that I'm trying to represent this. It may not be the best. The blue part is healthy weight, and the entire person's weight is the whole circle. With surgery, the green part, that's what surgery can help you address. It can help you address up to about 80% of the excess weight. Medications on average can help you address about 30%. Notice, neither meds nor surgery can help you get to a BMI below 25. Is that surprising for anybody? Okay, it may be surprising for patients though, because some patients are expecting we can get them to a BMI of like 18. We can't. We don't have a mechanism for that. Yeah. So the kinds of medications that we have, you've probably heard of some of these. Phentermine, been around for decades. Kissimmia, which is a combination with topiramate of phentermine. Contrave. Has anybody heard of Contrave in this audience? Okay, that's a great medication. We'll talk about it. And it's actually what's used, bupropion, Wellbutrin. You guys have heard of that? Yeah. And what's naltrexone? Anybody? Anybody? I know you know. One person, yell it.
Antabuse.
Yes. So it's used to block opioid receptors. And it's really effective. We'll talk about why. Orlistat, do you guys know what that is? Have you heard of that one? Stops your body from absorbing fat, so it goes out your butt instead. Can cause really bad problems sometimes. And then, of course, the GLP-1s. And then down at the very bottom is the only FDA-approved genetic target, and it's for something called melanocortin receptor 4. And it's actually a really critical pathway, the MC4R pathway for obesity, associated with Bardet-Biedl syndrome. You guys know what that is, which you do, because you're all like medicine people, and you know that better than I do by a lot. All right, so here are the three main categories. It's GLP-1s and pathomimetics and others. And here's just a little physical representation. The big difference being GLP-1s are injectable. So if you're giving your patient oral GLP-1s, they are not indicated for weight loss. They don't really have any data behind them that says that they work. It's not wrong to use them. There's a bunch of things that are used off-label, like metformin's used off-label, Vyvanse is used off-label. There's a bunch of others. Oral GLP-1s are too, but there's no true FDA indication for it. So just know that. The other things are pills. So phentermine, Contrave, Ally, they're all pills. Imcivree or setmelanotide, I hope that's how that's pronounced, is an injectable, but it is only used for the genetic condition it found. Okay, just to beat a dead horse again, I use the the example of myself as a 5'5" person. If I were 200 pounds, my BMI would be 33. My more healthy or ideal BMI of 25 would be 150 pounds. So my excess body weight would be 50 pounds. If I use medications, my expected result would be about 180 to 195 pounds. And if I had surgery, for which I would qualify under our society guidelines, my result would be closer to that ideal, much closer to that ideal weight of 155 to 180. There's nothing to say we can't use both, especially long term, but that's just the raw data. That's the raw expectations I would quote to a patient with a chart in my office. So there's that. All right, now let's go through the specific medications. So GLP-1s, the ones that have gotten all the news, all the press, all the everything. These are GLP-1 analogs, so they do interact with the GLP-1 receptor, and they do a couple of things. Well, actually, does anybody know? Who's done their biochem looking into this? Who knows what a GLP-1 agonist does? Anyone? It's on there, but also pretend it's not.
It slows down gastric emptying.
I love it, yeah. So gastroparesis is a really big part of this. It's both a good thing and a bad thing, and we'll talk about that. Anyone else?
I think there is also limited data that it can addiction because in term like as a GLP-1 agonist can be used in treating addictions.
Yeah. There's definitely some kind of neurochemical pathway that's occurring there with decreasing food noise and decreasing appetite or the stimulus for food. You're right. We don't know exactly why or how that works, but it is there. That's true. So it stimulates insulin production or secretion, I should say, not production, secretion. And then what opposes insulin in the body? Glucagon, yes. So what does it do with glucagon? It does the opposite. It decreases glucagon secretion. And actually, interestingly enough, this is also the mechanism that's occurring in your body when you have surgery, by the way, which also increases GLP-1 release, interestingly enough. All right, so because of that gastroparesis, by the way, you have sometimes nausea, emesis, cramping, bloating, diarrhea, constipation. By the way, there is a black box warning on GLP-1 medications. Anyone who has a history of medullary thyroid cancer or MEN2, I believe it's MEN2A specifically, either in their family or themselves, that is a complete contraindication of taking a GLP-1 because of the medullary thyroid cancer risk. I don't know if you know that, but that's really critical to know. Also, acute kidney injury, fatigue, and hypoglycemia, which is not common. It's not like you're giving people insulin. It's not the same thing. It's a 1 degree of separation away from that. So it doesn't usually cause hypoglycemia, but it can. And then over on the right, I actually just copy and pasted from a guide that I wrote on these medications. That's the dosing. So both, by the way, Wegovy and Ozempic are the same thing. They're both semaglutide, and they just come from the exact same company makes them. They're the exact same doses. One is indicated for diabetes, one is indicated for weight loss, but they're the exact same medication, equivalent completely. Yes, so Wegovy or Ozempic and Mounjaro or Zepbound is also what that's called, are used weekly. Saxenda is used daily. So that one, as you can believe it, is not really widely used because of the daily. These medications remain really expensive. I literally just checked today. Out-of-pocket costs for all of these medications remain over $1,000 each. The manufacturers do have vouchers available for about $500 a month at this point. Costco even has a program that's $500 a month now. And we are actually establishing our own 430B discount pricing through our own collaboration with the pharmacy department here. So starting within a few weeks, we'll be providing a much lower cost option for patients ourselves, which is really, really exciting. So please send all your patients, or please join us, because we'd love to offer that through our collaboration with you guys as well. All right, so some pathomimetics. These medications, probably deservedly, have gotten a bad rap. They are extremely useful for some patients, but they do have some side effects that can be pretty severe. Fen-phen was taken off the market in the 90s due to those side effects. Phentermine and phentermine topiramate, which is Casimia, remain on the market. These increase norepinephrine in your body. And what does that do? Anyone? Fight or flight response. Yeah. So adrenaline goes up, you get sweaty, your heart rate goes up, your respiratory rate goes up, you get clammy, all the things. So this is basically, remember we were talking about that metabolic set point? This essentially resets that metabolic set point up a little higher. So your metabolism goes a little faster. Makes sense, right? It also suppresses your appetite. We're not 100% sure why, but it does. And as a result of this, the side effects are pretty obvious. You can get heart palpitations, you can get irregular heart rhythms, dry mouth, insomnia, irritability. So in general, this medication is not recommended for anybody with cardiovascular disease, obviously, anybody with any arrhythmias, obviously, and it's recommended to do an EKG before you start this medication. In my own practice, I only use it for 6 months at a time, and then I take people off because the cardiomyopathic impacts of this medication are real. So beware. It's cheap. It's as cheap as $8 a month in some pharmacies, so access is pretty good. Long-term use is not recommended, but again, if you have a patient who really can't afford other options, doesn't have coverage, but qualifies for treatment, this is something to consider, especially in the shorter term. All right, let's talk about others. This is actually where I get really excited because most people haven't heard of Contrave. But Contrave is a really great medication. It is the one that we talked about, that's the Wellbutrin plus naltrexone combination. It helps to address food noise. And if anybody, well, you're a human, so you've probably heard of food noise at this point through a podcast or through something, through media, something, social media. For folks with obesity, food noise is a really big deal. Or anyone with an eating disorder, food noise is it's rate limiting to your entire life. It basically describes the feeling of food being somewhat of an obsession, somewhat of an addiction, not being able to do something until you know you're going to eat, what you're going to eat, when you're going to eat. And this affects a lot of people that have excess weight. It has a lot to do with mental health. It also has a lot to do with our culture. Our culture is one where we're constantly working, we're constantly transporting ourselves to work or to something related to that. And not always the healthiest options available for us, not always readily available. This medication is the best at addressing food noise. Contrave is an anxiolytic. It curbs the desire to pursue food. It helps with OCD. It's actually used for smoking cessation. That's where this came from. It was the only medication that helps people stop smoking that didn't make them gain weight. So it was studied for weight loss, and guess what? It was really effective. It also helps to cut appetite. It also has the lowest side effect profile of any of these medications. So yes, there's some of the GI effects. There is a black box warning for suicidal ideation with this medication, but outside of that, it's relatively affordable. There's a mail order pharmacy. By the way, I don't represent Contrave. I am not affiliated with them. It sounds like I am. I'm saying this more because everybody only thinks of GLP-1s, but there's actually other medications out there, especially if they're cheaper, especially if they're safer for some patients. So that's my really big emphasis with this. Out of pocket, it's $400. That's still really expensive, but through the voucher mail order program with Contrave, it's $100, so cheaper. Again, you don't have to use this medication, but it's an alternative. It's an option. Ally, the one that blocks you from digesting fat, really, it's a lipase inhibitor and a hydroxylase inhibitor. So it stops fat from getting absorbed by your body. That's actually really important in your body, right? So your A, D, E, K vitamins, blood clots, vision, that stuff, skin function. So I don't really recommend Ally commonly. However, if someone has fatty liver disease, this has yet to be studied, but there's some early data brewing that for some patients, especially those with fatty liver disease, this may actually be a first-line medication to consider. So some thoughts on that. It's also pretty cheap. Through a voucher program with a company, it's about $50 a month, and even out of pocket, it goes up to about $100 a month. So on the cheaper side. And then we get to the most expensive one on this list. So if someone actually has the MC4 receptor mutation that this targets, they can pay $30,000 a month and receive this medication. It is essentially curative. And this is hyperphagia, overeating a lot, and a lot of other symptoms that go along with this, and it essentially blocks that pathway entirely. So, unfortunately, we don't have any other medications on the market that target this pathway except this one. There are some like angel support programs for people who have this kind of Bardet-Biedl syndrome to support this medication. That's it. So kind of limited, guys. I hate to say it, but like we have all of these targets and we only have 10 medications that are FDA approved. We gotta get to work. We have a lot of work to do. Some things to consider. We don't have any guidelines on this, so I'm just being super open about that, but it's something that we need to study, we need to start working on, is combining medications with medications. There's a couple of reasons that's really important, not just for the heck of it, not just to say, oh, okay, we want a GLP-1 plus another GLP-1 or plus Contrave or something. Combining medications lets you lower the doses of those medications. And a lot of the side effects that we have, essentially all the side effects, are dose dependent. So if someone has that gastroparesis with a GLP-1 and it makes it intolerable for them to use it, if you can lower the dose by combining it with something like phentermine or Ally or Contrave, then guess what? Lower side effects, person can tolerate it for longer, take that medication for longer. It also allows you to use lower doses, which over time, we haven't really thought about this or addressed this, but we need to figure out how patients are going to use these for years, right? I don't know how to switch that back. Okay. Anybody know how to switch this back? Okay, no worries. We'll use this one for now. I can mind the rest of the presentation. It'll be good. So yeah, we can use lower doses over a longer period of time, even potentially at lower frequency if we're combining medications. So imagine we use a GLP-1 one week, Contrave the other week. We can actually alternate, for example. So none of this has been studied. None of this has data that I can present to you, but these are possibilities ahead that I think will start to be studied a lot more. And then, of course, lower cost. These GLP-1 companies need some competition. We need to start figuring out how to drive prices down. And I think combinations of meds will definitely start to accomplish that too. The other thing to think about, I'm a surgeon, so I'm trying not to be the person who only sees like, I have a hammer so everything's a nail, but surgery and meds can be an incredibly effective combination. There's really great research coming out where we actually plan to use medications in combination with surgery, either before or long term, and it actually creates better outcomes for patients. Even the amount of weight that they lose at their nadir, which is the most weight that they lose, is actually the most when we combine medications with surgery. So I want to get it completely out of our head that it's either or. It's not surgery versus medicine. I'm very overpowered in this room, I know. And you guys would win. I work out, but you guys would win. So start thinking combo, because that way we can get better weight loss, we can get better outcomes, we can start to think lower cost over time, and we can really think about even optimization going into surgery for patients. So some really good things to think about. This is a really busy slide. It went over really well with surgery residents. I will not make you walk through this with me, I promise. However, this is one patient, a 26-year-old woman who I've presented to you at different BMIs with different comorbidities, and we're thinking about what to consider for her as treatment. This is all based on insurance in this scenario, because again, if you don't have insurance, if you're paying out of pocket, you can start treating people at a BMI over 25, right? I wouldn't really recommend treating people at under 25, because there's no data to show that it accomplishes anything positive. But 25 plus, yes. But if they do have insurance coverage, and they're limited to that, then really our treatments are limited in some ways. So to BMI of 34, consider anything. If they have diabetes, consider a GLP-1. It's made for that. That's a great thing to consider. If they have cardiovascular disease and they didn't tolerate a GLP-1 very well, guess what? You still have other options. Contrave, potentially phentermine if you're willing to monitor it. If your patient's on the transplant list and they don't qualify for a transplant because they're at a BMI of 42, they've got 2 BMI points to lose. Use a medication. Please consider a medication. That person is waiting for a life-saving procedure, and they can get it if they can get their weight down by those 2 points. So it's a really good time to consider medication. Obviously, if someone has Bardet-Biedl, we have a medication for that. And even if we're talking about surgery, your patient has a BMI of 35 plus one of those listed comorbidities, or a BMI of over 40 without any comorbidities, again, it's not either or. It's potentially surgery plus meds. Any questions about that, by the way? I know this is a busy slide. It's kind of my cheat sheet go-to. What do we do about patients who have a BMI under 35? Because currently, there aren't a lot of really good options based on insurance. If you can pay out of pocket, any option is on the table, and people even go outside the country, for example, for treatment, for both meds and for surgery. We also have a lot of compounding pharmacies that are used right now. Hims, Hers, there's like thousands of options online to go to for GLP-1s. The FDA has started to crack down on that. They started to send cease and desist orders to a lot of these companies. So I assume over the next year, it may not be gone completely, but access will be limited. So hopefully programs like ours within the hospital, through the 430B and other programs, will start to be more affordable. And we even see Costco offering GLP-1s at $500 a month without anything like out of pocket. Something else that you guys should probably be aware of is endoscopic procedures. So we actually have a new CPT code for the endoscopic sleeve coming out in January of 2026. I hope we will be able to offer it here, but insurance is literally covering that for patients. And you may be saying, why? Just because we can, we're doing it? No. There's actually some really great times to think about endoscopic procedures for patients. For example, if a patient wants to be pregnant within the next couple of years, that may be the safest option for someone instead of going through an intra-abdominal surgery. Or imagine your patient has had a big open stem to stern kind of big whack surgery from the 80s or the 90s, and you imagine there's probably a lot of scar tissue inside. This actually may be the safest option for a patient before doing an intra-abdominal approach. There's a lot of others as well. End-stage disease, for example. Somebody can tolerate a scope much better than they can surgery. So even for our patients on the transplant list, for example, that might be an option. So anyway, endoscopic procedures, a lot more coming up on that. We probably need to do a separate lecture on endo with GI and talk about that. And then obviously medications. That's a really great time to think about medications. Cool. And then this is a TBD. I don't have any guidelines to present to you about medication tapering or what we should do about these medications long term. But these medications are just like treating hypertension. If you treat hypertension with a beta blocker and all of a sudden you stop your beta blocker, well, that's not even, what's the first indication for hypertension at this point? It's not a beta blocker. What is it? Sorry? ACE inhibitor. Okay, great. So you take an ACE inhibitor, you stop the ACE inhibitor. What's your patient's blood pressure going to do? Go up. Yeah. Okay. Same thing with this. If you are taking a GLP-1 for weight loss and then all of a sudden you stop taking it, what's your weight going to do? It's going to go up. Yes. So we need to start thinking about what we're going to do long term for these patients. We've been using these for a couple of years. What do we do for the next 10 years? What do we do for the next 20 years? What do we do as these patients go through menopause, as these patients go through aging? What do we do? Yeah, I don't have an answer for you. Because I don't know a lot of people that can afford $500 indefinitely for a medication for forever. Some of it's going to be, actually, I put this loudspeaker on here because I think part of this is advocacy. We already have guidelines that say we should be treating these patients at much lower BMIs than what insurance covers. And we all know that medications would help our patients, and yet there's essentially no coverage, right? So all of us, I think, should start to be thinking about advocacy. But yeah, so tapering. Let me just give you some specific examples of what this could look like. For a GLP-1, for now, semaglutide is recommended at a 2.4 milligram dose once weekly, and that's Ozempic or Wegovy. In my own clinic, I actually ramp people up much slower than that. So we start at 0.5 once weekly for a month. If we need to, we go to 1. If we need to, we go higher. Very rarely do we actually reach the recommended dose of 2.4. Because if someone's losing weight and we're keeping their side effect risk lower, that's great. So if they're maintaining at that weight long term, especially at like 6 to 12 months, maybe you start to consider giving that dose every other week. Maybe you start considering lowering the dose. Same thing that you do for hypertension, right? If your patient's really well controlled and they've done the diet and the exercise. If you're doing it with phentermine, same thing. Maybe you take a phentermine pill every other day, 3 days. I don't have data for this, but these are things that my patients started to do on their own in my clinic, and I learned from them. They were starting to space themselves out to every other week with their weekly medications or every other day, and it actually worked. It's pretty interesting. And then with things like Contrave, it's indicated 3 times a day. I'm sorry, it's indicated 2 pills twice a day at the high dose. And people were spacing themselves out to 1 pill twice a day, for example, and it worked. They were maintaining. So this is happening. Even if you don't think your patients are doing it, it is happening. And it'd be really cool to actually study this, research it together, maybe collaborate within our organization to study it, maybe with others. All right. Here's our clinic. The QR code, like I mentioned, goes directly to our website, so please look us up. And we are building a comprehensive program here with pharmacy, with our physicians, with our surgeons, with everybody's help. We really want to provide metabolic care over the lifespan to serve our patients and to serve ourselves. Because I think I get a lot out of treating patients this way. Debbie Bennett, my patient that was way back here, had a remarkable change in her life and her quality of life, both herself, her family, even the kids that she's a principal for. And she now had surgery a couple of years ago, and she keeps sending me updates, and every time it's full. So we really do a lot of amazing things for people when we treat them well. That's all I have. So thank you guys for your attention. I really appreciate it.
Any questions?
Yeah.
I have a friend. He's 31 years old. He's about 190 pounds. He's tried Ozempic, but he had to stop it because of the side effects, specifically heartburn, and he said he wasn't tolerating it very well. And then, he's tried other lifestyle modifications as well. I think his BMI falls just under 40, if not 40. He's not amenable to going directly for bariatric surgery at this point.
Yeah.
What advice would you have for someone like that? He doesn't have any comorbids. He may have some degree of sleep apnea. We're not sure.
So that's a really great question, because that's actually where a lot of our patients start. Is they don't necessarily want surgery, but they're there for you to help them. That's a good person to send to a program, to recommend to go see someone that does comprehensive care so that they can point you in the right direction. I will say that person may qualify for other medications. We talked about Contrave, Ally, and all the others. Or a combination of things. Again, maybe trying the GLP-1 with something else, possibility. But actually, I will tell you, so I treat people with medications, use quite a bit of GLP-1s. I've had a couple of patients land in the hospital from the effects of gastric crisis, and they need a reversal, they need treatment, the whole thing. I've never had that happen with a surgery patient, yet. So those effects are real. They can both patients were providers in a hospital setting, and those are nursing homes. These are people who I don't think were taking it, weirdly or doing something crazy, and yet they still landed in the hospital. So that is real. Yeah, I think another evaluation by somebody who provides comprehensive care, either with other meds and or surgery. That may be somebody that is amenable to an endoscopic procedure. Maybe they're amenable to a surgical procedure if they get the work and then they understand what they're going through. A lot of times people also in that range of 35 to 40 will actually have sleep apnea if they go through testing.
Yeah.
Or will have diabetes, or will have other conditions, hyperlipidemia. There's a few others that qualify. PCOS is a really big one actually that people don't realize. So for women, especially, well, women only, sorry. Don't know any men with PCOS yet. There should be like a male equivalent to that, but there's not. Anyway, so yeah, he may actually have some medications baked in there as well. So I would say go see someone, go talk to someone who can provide a more comprehensive. There's no easy answer to that. Yeah. Anyone else? Happy to take any.
So just for the group, if they want to refer a patient, so I tried this, so the phones won't allow us because it's.
Oh, okay.
It's the hospital block.
Oh, no.
So I just tried it. So how did they reach out? Would they
Yes.
call? What's the
So,
number?
actually, this should work, this link. Yeah, okay, cool. This is our link. So you can give us a call at 718-250-8920. That's our phone number. You can also email me. That's an easy way. It's my first name, last name. You can look me up in the system. I'm probably the only ILI. Okay, ILIAKOVANTPH.org. So email me, call me.
Dr. Iliakova, the number one recommendation I have is for you to put in a referral in Epic.
Oh, sorry.
So,
Okay, great.
St.
Better.
Bariatric.
I'm glad she's here.
Wait, say that again?
St. Felix Bariatric.
St. Felix?
Yeah.
Okay, and then you guys will contact the patient?
Yeah, it's always, when you're doing a referral, we love it if you could write something in there, something other than just putting a diagnosis, like if you could say patient want meds or patient's interested in surgery or something that's really helpful to us. If you can, it's no big deal.
And we will still discuss a comprehensive approach. So I didn't cover this at all, but the conversion rate between meds to surgery is about 30%. So about 30% of people decide that weight loss isn't enough, or that side effect was really bad, or that cost is really high, or something else, and they convert to surgery. So we talk about, yes, so please refer. And we're actually setting up, yes, I have clinic days on Thursdays for surgery and for everything, but with pharmacy, we are setting up dedicated just medication days. So within the next 12 months, we should have medication only visits available 5 days a week. 5 days a week.
And this will be at St. Felix?
This will actually be here in the hospital. So where the vaccine clinic is now,
Correct.
that's where that will be.
Okay.
But don't wait, just go ahead and refer right now.
Yeah, but go ahead and refer, don't wait. But stay tuned, there will be a lot more medical.
But again, if they put the referral, you would contact them.
St.
Correct.
Felix Bariatric, yeah,
Okay.
either the call center or of course,
Well, the call center puts it for December, we're looking.
No, yeah, I mean, she's brand new, so her
Right,
schedule's
so-
wide open, so now's the time to.
Bring it on, guys.
No, I would call you for the season. All right, cool.
But if you have a personal question about this, either you yourself, literally, because I've already been approached by some providers, which is amazing. But if you have any questions about how to do this, if you want to be part of this, let us know, because we're looking for people who want to be prescribing, who want to be involved in this. And the more you know, the more we can work on things like papers or specific things like fertility optimization, other kinds of things with you. We'd like to do that. Do not be shy. Get a hold of me. I'm obsessed with this, so please do not be.
Thank you so much.
Thank you.